Dr. Shelley with Shelley's Nursing Review. And today we're talking about PUD. And of course, this handout, which has this front, is available through my resources. And if you listen all the way through the video, I'll give you a freebie as well. We have lots of giveaways and I always want to give away something. So just listen till the, all the way through till the end. I'll share with you some ways to get some of these handouts and videos with handouts that correspond and all that good stuff. So right now though, focus, really focus, because peptic ulcer disease, we want to talk about everything from the causes to risk factors to complications. Today, we're going to also cover signs and symptoms, the diagnosis, and how to treat it. Now, peptic ulcer disease is very, very much like the other video I did on gastritis. So you'll see some overlapping. And of course, if you are smart, you listen to the gastritis video first, and then this one naturally flowed right in line. Now, if you know anything about my YouTube channel, you know that if you go to the playlist, unlike other nursing video channels, my playlists are organized in body systems and diseases. So you will see a GI playlist, which this will be contained in. You will see a respiratory playlist. You'll see a cardiac playlist, psych, maternity, peds, so there's a playlist for every body system or disease process. So let's get started on the GI playlist, or specifically chronic GI. Now, the peptic ulcer disease itself is more chronic, but some of the complications are very acute. So I will kind of overlap a little bit, but for the most part, I need you to focus in on acute GI being those conditions which, if we don't hurry up and treat you, you're gonna die. Otherwise, this type of stuff is something that the patient will live with for a while, if not forever. They will have to manage it by taking medications or doing certain therapies for the rest of their life. So let's dig into peptic ulcer disease. Peptic ulcer disease has as its main cause H. pylori. And you might have heard everybody talking about H. pylori and still be very confused about, well, what the hell is that? Well, it's Helicobacter pylorus. Yeah, what is that? So Helicobacter pylori, H. pylori, is an infection, and you can get it through oral to oral or fecal oral transmission. I know, it doesn't sound good, does it? Yeah, exactly. But that's the way it is. It's an infection that is extremely common. Lots of patients with the gastritis that I covered earlier, they have H. pylori. Patients with ulcers most likely have H. pylori. It is the #1 primary cause. So you have to know that if you're taking an NCLEX exam or if you're trying to pass a unit test in nursing school. Now, another cause that is often missed because we just don't take over-the-counter medications seriously are Nsaids. And you have to be careful, nurses. You have to be careful never to include Tylenol with your Nsaids, because Nsaids are ibuprofen, Motrin, Advil, Aleve, and even aspirin to a certain extent. But normally when you hear us say Nsaids, just think to yourself ibuprofen, Motrin, Advil, Aleve, and there are other names for some of those meds. Like if you think about Aleve, the other name for that is naproxen or naproxen. And people abuse these drugs all the time. They are great for relieving pain, but they're horrific if you don't use them wisely. So let me explain. If you get frequent headaches, if you get menstrual cramps, if you have arthritis, if you have aches and pains for whatever reason, maybe, I don't know, you're an athlete or got something else going on, or just pain in general, chronic pain. This medication you have to be very careful with, because these over-the-counters, ibuprofen, Motrin, Advil, Aleve, naproxen, whatever, these medications, when used over time and in high doses per day can cause some serious problems to your GI system. And when I say high doses, long-term, whatever, let's make sure you know what we're talking about, because, you know, folks outdoors, laypersons, even my students, patients for sure, they don't know what in the world is an appropriate dose or usage of these meds. So let's remind each other of how much or how long or what you should be doing. First of all, pain in general should be short-lived because it's a symbol of something bigger happening. So I always say if you're taking medications longer than a couple of weeks and you haven't had a workup for whatever the hell it is you keep taking medications for, this could be a problem. So when we look at ibuprofen, Motrin, and Advil, we cannot put those in the same category as Aleve, because Aleve is a completely different drug, okay? Yes, it's an NSAID, but it's a completely different drug. And Aleve is another name for naproxen or naproxen. So when we have a patient and they're experiencing some gastritis or gastric ulcer of some sort, or duodenal ulcer, or whatever their deal is, I often say to that patient, are you taking Advil? I don't say, do you take Nsaids? I say, do you take Aleve or Advil or ibuprofen, Motrin, whatever? And I find out that a lot of these patients are taking 2 to 3 over-the-counter pills every 4 to 6 hours. Hello? That's way too much. And then because the average person doesn't know the difference in in over-the-counter meds, they are taking the exact same dose with Aleve, which is your naproxen, right? So if you were to take 2 to 3 Aleve every 4 to 6 hours, you have triple overdosed yourself, because actually Aleve is, if you're dying, the pain is like so horrific that you are dying and you take 2 Aleve at the same time, you don't get anything else, honey, for 12 hours. But people are abusing these drugs and they're just taking them like by the handfuls. I'll never forget, one of my students came to class and she was dizzy and her head was on her arm on the table. She couldn't hardly concentrate during class. I asked her what was wrong and she said, and I quote, "I have really bad menstrual cramps, and for some odd reason this time around I'm really dizzy and I feel like crap, like I almost fainted coming up the stairs to class," and blah, 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 blue, blue, blue. And I'm like, oh my God, so what are you taking for the cramps? Well, it's not working, but I take like 4 or 5 ibuprofen or Motrin or whatever, Advil or whatever, at least every 4 hours, because it's so, I said, stop right there. I said, did you drive yourself? I did. I said, okay, well, I'm going to have somebody drive you to the nearest hospital, because I actually believe that this is not just a menstrual cramp issue. You told me you were dizzy, you almost fainted coming up the stairs. And yeah, she had a GI bleed. And yeah, she had 7 units transfused over the next 36 hours. So she was so anemic that her hemoglobin, the one that should be somewhere between, anywhere over 12, her hemoglobin was 4.9. Cray, right? It should be 12. So I'm telling you what I know, and that is that Nsaids can be very, very damaging. Now, you have to know how they damage, right? We like pathophys around here. H. pylori is an infection, you get that. But how do Nsaids damage the GI system? Well, there's a chemical called prostaglandins, and it protects your mucosal lining of your GI system, and specifically your stomach. When we take Nsaids, it stops, blocks, inhibits prostaglandins from protecting your stomach. And so now you have a situation where the acid that's normally found in your stomach is literally eroding your stomach and causing a deterioration of your stomach, literally just inflaming the entire stomach with this Motrin or Advil or Aleve or whatever it is, being the root cause of why there's nothing to protect your stomach. The other issue, and I want you to hear me clearly on this, is that after time of taking all of these Nsaids all the time, every day, every 4 to 6 hours, over the counter, 3, 4 pills. When you're doing that, eventually as you erode the lining of the stomach, the whole function of the stomach doesn't work as well. And then you have a situation where you're not going to produce enough acid at that point to even continue your digestive, actions that you need to digest your food and to carry on normal bodily function. Yeah, it gets really bad, you guys. Now, so what do we have? We have H. pylori as number 1. We have Nsaids as number 2 cause. And some would argue that alcohol is a risk factor. Some would argue that alcohol is a direct cause. I don't care. You call it tomato, I call it tomato. Any way you look at it, alcohol plays an integral role in destroying your GI system. Specifically, I always tell you to look for this in every alcoholic. In other words, be on the alert that alcoholics are very commonly at risk for GI bleed. And the reason that GI bleed exists is because a pre-existing ulcer was there beforehand. So when we look at alcohol, remember what it does. It increases acid in your stomach. And a lot of people drink on an empty stomach. So now you're increasing the acid on an empty stomach where the food would have at least absorbed the acid and it wouldn't be so corrosive. But yeah, with this alcohol, especially binge drinking, remember I taught you that it's a chemical. Alcohol is a chemical. It burns. If you reflect back at 12 and 13 when you first took your first drink, you would remember that that shit burned going down. Well, guess what? It still burns, and it burns the lining of your esophagus, your throat, your stomach. It just goes all the way through the digestive system, burning on its way. So this is a big, big issue. Now, if we look at risk factors, which are not necessarily causes, you couldn't really say they caused the peptic ulcer. We know that smoking is a risk factor and will irritate the digestive system because it also cuts down on the blood flow, the perfusion to the GI system, specifically the stomach. And when you do that, you pretty much have a situation where your stomach is not doing what it's supposed to do. Okay, the stress, I know it doesn't cause a peptic ulcer. That was an old wives' tale. Stress does not cause a peptic ulcer. It's the same thing as if I tell you salt does not cause hypertension. But if you've got high blood pressure, salt will aggravate the hell out of it, right? Well, that's the same thing with smoking and stress. With stress in particular, stress did not cause the peptic ulcer, but it surely aggravates the hell out of it because I don't know if you get it, but we know that students in the past have told us they get bubble guts right before they take their test. Your nerves, your brain, your emotions are tied into digestion. So that's why diarrhea, cramping, tummy problems, bubble guts, whatever you want to call it, exist when you're nervous. Well, the same is true here with stress, except in addition to the stress being, really contributory to digestion and tummy problems, it also vasoconstricts just like that cigarette. Remember with the cigarette, you cause vasoconstriction for a whole hour, which means cutting down on the flow of blood and oxygen to the GI system and every other body part for that matter. Well, stress does the same thing. A stressed out person vasoconstricts for a whole day, depending on how stressed they've been that day. And that cuts off oxygen, nutrition, and blood flow to the gut as well. Okay, then we have a situation where alcohol is repeated. Just in case you didn't catch it the first time, I'm coming all up your backyard and through your parking lot to make sure I put this here in a way to remind you that there's no way to talk about alcohol without talking about digestion. Okay, all right, now, so we're good, right? We got our causes of peptic ulcer disease. We've got our risk factors for peptic ulcer disease. And if you've looked at my gastritis video, these look a lot alike. I mean, because they are. And indeed, I mentioned in the gastritis video that a patient that has gastritis is at very high risk for a peptic ulcer. Now, pay attention to a little note up here. There are technically 3 types of ulcers. And one is gastric, the other one is duodenal, and the third one is stress. They are not the same. They are overlapping a little bit, And we're gonna kind of have a compare and contrast between these three types of ulcers after this video in general about peptic ulcer is done. So you'll get to know how to compare and contrast that, especially for things like select alls on NCLEX or any unit test in your nursing program. So as we move on, let's look at complications. When we look at complications for peptic ulcer disease, you have to remember that these complications will throw a chronic GI condition into an acute GI emergency, okay? I'm gonna say that again because it's really, really important. The patient who has complications from a peptic ulcer disease will go from a chronic GI condition into an acute GI condition. So let's see what throws you over the fence and into the woods, into the life-threatening acute GI disorders. Hemorrhaging, number one. To be honest with you, patients with ulcers don't usually even know that they have an ulcer, because ulcers may not really be symptomatic until all shit hits the fan and you show up in my hospital bleeding. A big portion of the patients that I take care of on my unit have GI bleeds. And those GI bleeds could be for any number of reasons, but more often than not, the patient has a history of heavy Nsaids use, the patient drinks, the patient may or may not have gone through a workup, but if they have, they've had a history of peptic ulcer disease. They report GERD or heartburn or reflux, acid reflux. Those patients have had this long-standing history of different problems in the GI system, and many of them do smoke, and a whole lot of them are super stressed, like, business owners, or, you work in a really high stress environment, sales, that kind of thing. So this hemorrhage or GI bleed is very, very serious. And the type of GI bleeding can range all over the place. Let's explain. If a patient has a bleed, it can show up in different ways all over the map. It could be hematemesis, blood when you throw up. That blood when you throw up could show up as bright red bleeding, or it could show up as coffee ground emesis. Don't focus too much on those two things, except to understand that depending on where the ulcer is in the stomach, if it's a gastric ulcer, the higher it is up in the stomach, the more likely you'll see bright red bleeding coming out of the mouth. The lower it is in the stomach, the more likely some digestion will have occurred and you'll see coffee ground emesis. Now that's a gastric ulcer. When we talk about the differences between the two ulcers, you'll learn that the duodenal ulcer, which technically takes place in the small intestine, that ulcer will have something called melena, right? Melena. That's called dark tarry stools, okay? So if you have a patient who is having a GI bleed, it will either be dark tarry stools because it's already gone through digestion, and remember that blood is a protein, and as such it gets digested through the system, or coffee ground emesis and bright red blood, throwing up bright red blood. Those things are never good, right? And remember, when you're going through a hemorrhage or in any way, shape, or form, in this case a GI bleed, an upper GI bleed typically, you're going to be anemic. So with that can come the dizziness, the syncope, the weak thready pulse, you know what I'm talking about. Now, so that's one. Another experience that I've had with my patients in the unit that I work in is perforation. And usually I don't get them when they're in the middle of their perforation. That is more like ICU and head straight to the OR. However, I have had patients who are on my unit that had this history. So what does that mean? It means that this peptic ulcer is so severe that it has eroded through the lining, all the muscle layers, and there's basically hardly any organ or muscle tissue left at all. In other words, if it's a gastric ulcer, it's eroded all the way through the very bottom layer of the stomach. If it's a duodenal ulcer, it's eroded all the way through the bottom layer of that part of the duodenum. This is horrific because that means that all the contents of this perforation in this body part, let's say the stomach contents or the duodenal contents, all the things that were supposed to stay inside the duodenum or the stomach are now spilling out into the peritoneal area. And when you have a perforation, that is a medical emergency. When you're talking about a patient that has a perforation, remember the classic hallmark signs, right? Tender, rigid, board-like abdomen with rebound tenderness. You know what I mean, because those are the same symptoms with a GI bleed from a perforation, peritonitis, ruptured appendix, ruptured ectopic, even in pregnancy, placenta abruption, anything where the contents of a certain area spill out rapidly into the peritoneal area is called a perforation. So ruptured appendix, ruptured ectopic, ruptured or perforated ulcer. You know what I'm saying? You got me? Again, I think you better write that down. Tender, rigid, board-like abdomen with rebound tenderness. GI emergency all day long. And I don't know if you remember your acute GI that I always share with you guys in the same playlist as this one, but I don't know if you remember me giving you that Jay-Z rhyme for the whole GI emergency patient, but just in case you forgot, I'm gonna run the tape back, so hopefully my girl will follow me. For all GI emergencies, we are IV NG, Foley surgery, electrolytes, and antibiotics. Now, what the hell? I am just giving you a little treat of acute GI emergencies in my chronic GI lecture just because I love you. Okay, boo? So let's remind our little selves. IV, NG, Foley, surgery, electrolytes, and antibiotic replacement. IV, NG, Foley, surgery, electrolytes, and antibiotic replacement. Whoa, knees. Yeah, this is not ortho, it's GI, I forgot, God, me. Okay, so anyway, what are we talking about with the IV? IV times 2, 18 gauge, large bore. Why? Because your ass might need to transfuse. What are we talking about with the NG? Well, at least NPO, and if they can't stop vomiting, you're gonna have to slide an NG tube down their nose, hunty. What are we talking about with the Foley? Only and only if we need surgery. We surely don't want to be poking around in the bladder while we do it. Surgery, oh yeah, for sure. This perforated ulcer will absolutely need surgery, and they'll get like a washout of the whole bowel area and repair of whatever, right? Electrolytes, oh yeah. Anytime we're talking about the GI system, you have to remember that the electrolytes are usually screwed up. Yeah, electrolyte replacement is usually potassium and magnesium, both. All right, now antibiotics. Oh, I hope y'all remember all the shit I done taught you. Because with antibiotics, what do we say about GI? All GI is dirty. So if all GI is dirty and you've got the contents of the stomach or the duodenum or any other ruptured organ spilling out into the peritoneal cavity, that's nasty. We're talking E. coli, right? We're talking E. coli everywhere, or basically poop type substances and bacteria everywhere throughout the GI system. And in that situation, yeah, you're gonna need some antibiotics. And like I said before, in this case, it could even be H. pylori spilling out everywhere. That's a little bit disgusting, to say the least. Now, that was for free. So I'm going to erase that because hopefully you wrote that down. And if you didn't, well, there's at least 3 or 4 other videos that say the same damn thing. Get over it. Now, another complication of a peptic ulcer disease is your patient could get a bowel obstruction, aka paralytic ileus. Now, don't let that bite you in your butt. It's a $4 word, it's true, but let's just look at it. Can you look at it with your girl? Paralyzed bowel, right? So if your bowel is paralyzed, is the damn thing moving? Hell no. So it's a bowel obstruction, right? So this paralytic ileus is often just due to the fact that you're not getting a whole lot of blood flow to the bowel, and your bowel is like, okay, you don't want to perfuse me, I don't want to work. So I'm just not going to work. And so this is where we see that. Now, any one of these crazy things on this board right here could lead to shock. What kind of shock, Shelly? Because there's a million different shocks. Well, first of all, if you're losing blood or things have perfed, we are going to have a lot of fluid and blood coming up missing. And so this would be hypovolemic shock. Now, don't get it twisted. All shock has a low blood pressure, and all shock with that low blood pressure could make your kidneys fail. So this patient going into shock is the worst possible thing that could happen. But I have seen it. I swear to God, I've seen it. Okay, so just stay with your girl and remember this. Now, we're moving on over to this side of the board because we're going kind of fast. We want you to be sharp, but we're doing big things here. Now, I'll split it up a little bit because it's not hard. I'm going to go over the signs and symptoms, talk about the diagnosis, and then we will compare and contrast the gastric ulcer with the duodenal ulcer and teach you how to treat it. Is that fair? I think that's fair. It's more than fair because some of y'all got that ADHD thing going on, need a little bit of break and need to go outside and play in the dirt and, you know, take a drive to the ice cream store. I get it. I do. So let's just kind of hang in there a little longer. Here we go. Signs and symptoms. Epigastric pain or left upper quadrant pain in the case of a gastric ulcer. Remember how I taught you in the gastritis video that every time I say gastro anything, it means stomach? Well, let's look at the little trick that I gave you guys in the gastritis video. I'll give you the same trick here, you know, today for this peptic ulcer disease. What I did was I made our stomach, and I tried to make it in the 4 quadrants to teach you this little trick right here. I don't know if your teachers taught you G.L.A.S.S, but it's the neatest trick in the world. And the way this works is you take my belly, and here we go, my big old fat belly, and you split that puppy up, okay? I drew a line here, and then I drew a line there. And so if you look at my belly, that's taking my belly from the epigastric area all the way down to the pubic bone, and then it's taking a line through the belly button all the way over to the other side. So right here, if you're paying attention, right here is the belly button. And again, you have to be careful because you got to be facing this way to get this shit right. So up here, right? Up here is my right upper quadrant. Down here, my right lower quadrant. Then there's my left upper quadrant and my left lower quadrant. Now, you have this mnemonic called G.L.A.S.S, but I want to also give you one more thing after G.L.A.S.S, so you have to stay with me. Here's our G.L.A.S.S. You take the letters and you place them in the right quadrant. G.L.A.S.S. What's in the right upper quadrant? Gallbladder and liver. What's in the right lower quadrant? Appendix. What's in the left lower quadrant? Shit. I'm sorry. I'm so sorry. Yes, it is shit. So if you're constipated, that's where you're going to find it. But some of you are really nice people and you don't talk like me. And if that's true, then you probably better just put sigmoid colon, or if your kids are looking at you, or, well, your mom or dad could be looking at you, depending on how young you are. You know, I've got LPNs in my class that went through LPN school through high school. Yeah. So shit or sigmoid colon. And here we have stomach. Is that right? Okay. Now you also have a little tiny S up here. Don't get it twisted. That's the spleen. Why is it so tiny? Why is it away from everybody like it's not being accepted into the neighborhood? Well, it's because this little tiny little S, the reason why it's so small is that the spleen is not technically a GI organ. It's just contained in the GI cavity. It's actually a lymphatic organ, very most useful in infection prevention and the immune system. But the other organs are here, but then look at this. Now you don't have to do this on yours, but I always do it on mine. I make an umbrella and then an arrow. And what is this umbrella and this arrow? Well, this represents, I'm gonna write it, you can write yours if you want to. This represents the epigastric area. Epi what? Gastric. Did I say gastro is stomach? Okay. Now, what is this organ? It's the pancreas. And while your pancreas is not involved in this fiasco, it is in the same area that you would have the pain if you had a peptic ulcer. If you have a gastric ulcer, which is a type of peptic ulcer, then you might feel a little bit more in the left upper quadrant of your belly. But this is here just to get you to know your body parts, okay? Because that's going to be important. Now, what other signs and symptoms does a patient have? Well, they've got dyspepsia, which as you know is heartburn and this gnawing, burning, aching feeling at the top of the stomach. Some people call it reflux, some people call it heartburn, whatever. Hiccups, some people have. You can see hematemesis, melena. We've already talked about the GI bleeding. If you're bleeding, of course, you could have anemia, but there's another reason why our peptic ulcer and gastritis patients have anemia. And I really want you to remember this because most of my students don't know this until they get in my class. But when you have any kind of GI issue like gastritis or peptic ulcer disease, you are going to have a problem with your hydrochloric acid. And this acid is actually needed to help you absorb iron, vitamin B12, calcium, and vitamin D. So if you're not absorbing iron for whatever reason here, or B12 here, either the iron deficiency will give you anemia, or the outright GI bleeding will give you the anemia. Either way, the patient's at very high risk for anemia. And let me say something, because I always save a life if I think to remember to say this. Any male, any adult male with anemia has colon cancer until we prove they don't. So all adult males with anemia need a colonoscopy. For real. I have really bad horror stories where the patient is dead now. Not even a patient for me, a student's husband, where he went on for a couple years with anemia and it wasn't really worked up the way it should have been. And he had stage 3 to 4 colon cancer, died a couple years later. So don't forget that these are some of the signs and symptoms. Now, the last part of this is kind of easy, and that is, how do we diagnose peptic ulcer disease? Oh, that's simple. We do an EGD with biopsy. Now, we use EGDs also in GI emergencies. So if you want to throw a little monkey wrench into our rhyme, you could have said IV, NG, EGD, and Foley, surgery, and you could. Now, so if we look at this EGD with biopsy, remember it's the gold standard for working this patient up. And the biopsy is for the H. pylori, and also to make sure, because honestly, the same signs and symptoms for a peptic ulcer disease include the same signs and symptoms for cancer. So the only way to diagnose cancer is a biopsy. So we do an EGD with biopsy. Now you might be going, well, what the fuck is an EGD? Are you ready? Because I'm going to sound real intelligent here, like with $4 words. No. Actually, these are $5 words. Esophageal gastroduodenoscopy. I sounded so sexy, didn't I, with that? I'll say it again. Esophagogastroduodenoscopy. Esophagogastroduodenoscopy. You got it right? Yeah, okay. Remember, you chose me. I didn't look you up. You went to the damn YouTube playlist and you found me. So it's your fault what you get. Urease breath test. This is just to see if you have an active H. pylori infection. And there's different ways to do the test. You can swallow a capsule, you can take a drink, whatever, but you blow your breath out and they check for CO2 levels and then some. So there you have it. Now, I am tired. Yeah, I'm tired. So I'm going to go take a little break, eat some ribs. Yeah, like meat, honey. I can't help it. But I'm going to go eat some barbecued ribs and probably drink some Crystal Crack, which is bad for you, and that's okay. And then maybe like eat some candy, like some high chews, like I like those. And then I'll be back to compare and contrast the gastric ulcer with the duodenal ulcer, and then talk about treatment. Is that fair? Good. Deuces.